Muy buenas tardes a todos.
Good afternoon. Thank you very much for joining us this afternoon. My name is Carla Ruiz de Castilla from Unión Latinoamericana contra Cáncer de Pulmón. Be most welcome to the Precision Diagnosis in Lung Cancer. This afternoon, we have Alberto Fernández Villar, leader of the Pneumologist Center of 2B Vigo, Associate Professor of Medicine, and Coordinator in the Vigo Sanitarium University, Santiago de Compostela of Spain. We also have here with us we will be explaining the biomarkers and precise diagnosis. Dr. Edgardo Santos, medical oncologist from Florida Precision Oncology, specialist in thoracic oncology, and who has received the award Spirit of the North American Cancer Society and chairs the committee of the Clinical Oncology North American Society program, FLASCO. We will also have here with us Dr. Rodrigo Mota, oncologist doctor, graduate from Universidad Cayetano Heredia, Peru. He is a member of ASCO, ESMO, and ISHCL, oncologist doctor and researcher of thoracic neoplastics of Aliada, Peru. As you know, in Peru, we have a regulation related to lung cancer. We will be addressing this topic and the needs we have for cancer patients and especially those with lung cancer. This afternoon, I would like to welcome the leaders of patients organizations from Costa Rica, Guatemala, Salvador, Honduras, Guatemala. We also have patients organizations from Mexico, Peru, Panama, Colombia, Ecuador, Bolivia, Venezuela, Dominican Republic, Argentina, Brazil, Chile, Paraguay, and Uruguay. Thank you very much for joining us and always for that willingness to learn more and to pass on this knowledge to the patients we support. Be most welcome, Dr. Alberto Fernández Villar. Be most welcome. Thank you very much for joining us this afternoon. Over to you with the precision diagnosis and good practices. Good evening from Spain. It's such a pleasure. Thank you very much for having me, and I'll be pleased to contribute with some information to help fight this terrible disease, which is lung cancer. I'm going to offer a brief presentation. Let me know, please, when you see my screen. Not yet. Just a second, please. Okay, just a second. I'll give it a go. No worries. Also, our technical support can help us there. I'll give it a second try. Well, first of all, thank you very much for joining at this time. We know that it's very late over there in Spain. Yeah, it's nighttime, but it's never late to fight this disease. So if we can contribute somehow from Galicia, and Spanish community is so close to Latin America. Yes, we see the presentation. All right. This is a very attractive name for a pneumologist that does diagnosis of lung cancer, a diagnosis that has been going on I've been working for over 20 years, directing a cross-functional professional team for diagnosis of lung cancer in our Vigo area that includes the south of Galicia and a reference center of this area. We're talking about a terrible disease. This disease, apart from being some of the first causes of neoplastics at world level, is one of the main fatality causes due to cancer in the world, doubling or 3 times over the prevalent ones like colon cancer, rectal cancer, or breast cancer. And this is mostly due to the late diagnosis, and we diagnose a very high number of patients with the later stages of the disease or with other metastases. However, in recent years, we are seeing moments of hope moments of hope because of the developments we had in the treatment of lung cancer and some other factors, like therapies directed to risk factors. But about the diagnosis therapy and precise diagnosis and precision diagnosis, what we did in the past few years was we saw the appearance of new drugs and the combination of that with more knowledge of the disease. That is increasing the survival and increasing the life quality of patients that we diagnose with lung cancer. We've recognized many molecular. We used to characterize in cancer in different ways. Now we have one extra one, not only specific targets for molecular treatment, but also for those expressions of markers that can tell patients how to get benefit to them from immunotherapy, which is a great alternative from traditional alternatives. So we know there are drugs approved, and the next speakers will speak about this in detail. They are oncologists specialized in lung cancer and experts on that. I am a pneumologist that does diagnosis. I try to do the diagnosis and manage it for this to be done in the most efficient and safest manner. We will know that they are approved in Spain and in many other countries in Europe, in the north of America. They have approved combined therapies, immunotherapy along with them for systemic diseases and advanced locally diseases after chemoradiotherapy. But there is evidence, scientific evidence so far, and I expect that in coming months there will be indications of treatments with immunotherapy apart from molecular treatment, like extra assistance for early stages. Let's not forget that along to all of this development, there are also improvements. There is progress in treatment and diagnosis techniques. For example, echobronchoscopy, more than evolution, is a revolution, and positron tomography and the characterization of patients, such as better predictive capacity with techniques, cardiorespiratory, functional, and progress in radiotherapy with proton therapy. Now, talking about precision diagnosis of those patients with lung cancer suspicion, is different to separate this from the context, as I try to present on this slide. Here I'm explaining how the process goes from the assistance till a therapeutical decision is made, and it's difficult to split one part from the other, from suspicion to a decision, until there is a decision of a multidisciplinary committee supporting decision making and deciding on treatment, monospecialty or combined, the most adequate for each specific patient in each specific context. So staging, characterization, and functional evaluation is difficult or practically impossible. We also need to do it with efficiency, effectiveness, safety to patients, trying to provide equitable care to all of our patients. Disregarding of where we work, focusing on adapting this to each case, trying to prevent the patient being lost from one hospital to the other, and to choose the best one. And this is a disease that doesn't help. It is expressed in diverse manners, 15-20% in some series, even more with a systemic because of metastasis. Sometimes there are non-specific symptoms, and the cough cardinal are only in less than 50% of the patients. Some other patients will have some other types of alterations, and it doesn't help with the characterization of molecular process in the right manner. X-ray has high sensitivity, but reduced specificity. So it's easy to confuse with other infectious process. TAC helps characterize the tumor and to do a diagnosis approach, especially looking at which diagnosis technique we should look at. If we are going to start with bronchoscopy, the traditional one, or if we are going to do diagnosis through biopsy of any satellite acceptable injury, or even at hepatic level, it is advisable for studies to include from the neck till the upper abdomen. And the PET provides lots of information on the mediasthenic characterization and silent metastatic disease. 10 or 20 patients can get to this, and this was not provided by previous techniques. Let's talk about the diagnosis process to define a type of tumor and to characterize it molecularly. They go along in the same scenario, and it is difficult and almost impossible to split. This is a kind of a standardized process. We need to find those places with better accents if it's the first time of metastasis and there is an adenopathic conglomerate at a supraclavicular level that is not frequent, we will have to go to the closest access by puncture or biopsy, partial biopsy of the injury that can provide us the most information possible. If that is not like this, and if we don't have access to those, because the injuries are in the thorax or there is an extended to other organs, we will have to put it in stages and get the best possible sample to characterize this from histological point of view or molecular point of view. There are different scenarios and very different techniques based on each one. And customized, personalized attention is also part of the diagnosis, finding that technique that helps us put in stages in the fastest, more effective way, getting adequate samples for histological and molecular characterization with just one test if possible, because there is evidence that delay in diagnosis and onset of the start of treatment are related to many other factors, like the number of tests needed. Therefore, the possibilities we have apart from bronchoscopy and other techniques, biopsy, punction, echobronchoscopy, that is highly variable. And sometimes we can have samples in cytological and plural, some techniques that are even surgical techniques needed, if they will open possibilities of offering targeted treatment, if it is necessary to go for surgical techniques, if that is safe and there is a professional team experience on that, that shouldn't be ruled out. Many patients will go for radiology interventionist techniques like punctures or PAC in our own service. If the injury is at the level of the pleura, we can even do it by guided techniques or adenopathic lesions. It is important to adapt our diagnosis process to each scenario we have. There are 4 scenarios for characterization of thoracic lesion. If it has lymph nodes affected, if they are bulky adenopathies, or if they are small ones, or if there is a suspicion that there might be a mediasthenic silent effect. There are different algorithms that will help us target diagnosis tests, but we will also have to pay attention to the availability of such techniques in each health center, and that's something that we need to take into account. Maybe the highest and strongest revolution allowing us access and coding and diagnosis are the echo-guided techniques. Our service provides us the possibility of having a pathologist in our area doing evaluation on site of the sample, letting us know if we should go for further puncturing of each lymph node in each node to characterize not only the type of tumor and see if that node is affected, to track it, to see if that is affected. He will also help us know if the sample is adequate for later marker, as recommended nowadays by different scientific societies in each clinical stage. And eco-guided techniques, more than evolution, it is a real revolution. In some patients, I don't rule out even getting access through surgery to get the good sample. There is huge progress in biosurgery, and patient can get a diagnosis, biopsy, and therapeutical one to allow us get samples that we couldn't get through less invasive techniques. Nowadays, we can release with video surgical techniques in 48 hours in hospital. And there are even groups that in 24 hours on the very same day, they do it in the morning, and they can send patients back home in the afternoon, obviously with due safety and with a reduction in cost for the sanitary health system. I'm sure next speakers will describe these targets, therapeutical targets we have. Nowadays, we cannot be, it won't be enough with the first two tests we had 20 years ago. Now we have to characterize chemically the tumor and molecularly characterize it as well. There are many essential tests to do so, at least a first approach, looking at the expression of the receptor, looking at the rearrangement of LK and also the SGR mutations, depending on the possibilities of each center, and sometimes they need to be sent to other centers highly experienced or with more experience, and that requires management and delays in the access to drugs and therapeutical properties for our patients. I'm sure we'll see that in a minute. There is opening to hope of survival of patients with advanced cases and locally advanced cases. In Spain, we follow the guidelines of the Thoracic Oncological Society, and in the beginning, most of the centers in advanced locally tumors, if a carcinoma is a squamous carcinoma, they only do molecular tracing. We get a sample of the expression of PLDL1, and the other one that's done in only young patients or non-smokers, and we have to check in Latin America to see if there is a frequent index of patients, non-smoker patients with lung cancer. So patients with non-squamous cell carcinoma will have to do all of this set of tests, and it is very probable, and probably in the coming months and years, we will have to go through all of them. The sample quality becomes essential. Probably the liquid biopsy will not maybe or might not be an alternative, immediate alternative to this initial approach. Why? It will probably allow us to see new mutations, but it keeps being costly and non-standardized technique for all of the centers. It requires specific infrastructure and non-accessible to all the sanitary systems. With that, for now, the approach in most of the patients to this diagnosis and molecular characterization will be done through the techniques I told you about. It is not useful to take samples and diagnosis if we do not stage the patient adequately, and this goes hand in hand with the two techniques. Sometimes some techniques, a staging of N2, will put the patient in the therapeutical window we need based on the real stage T. And it's been commented in previous sessions that's the main prognosis factor for patients with lung cancer. Let's not forget that at least where I work, patients, there are many coexistent diseases apart from tobacco consumption and other type of pathologies. Most of the patients in Spain have comorbidities, especially emphysema, more and more frequent because of the survival of fibrosis and occupational diseases, and that play a factor in the diagnosis and stages. Now, molecular target allow us to offer patients with lower functional criteria or resectability or invasive treatment will offer another alternative, and it opens for the need of doing precise biopsies to those patients with significant comorbidities when we are running functional test or comorbidity, cardiac comorbidity test or respiratory ones like the cyclospirometry. Let's not forget that a frequent percentage, up to 20% of series of patients, come with small lesions, pulmonary nodes, especially as we improve the screening systems, the screening programs, this becomes more and more frequent. There are different clinical scenarios. There is a problem here to get access to such a small lesions. In the diagnosis of the solitary lung node, there are many possibilities here, and we have to compare that with other factors. The cost effectiveness of this is between 20 to 60% based on the size or existence of neoplastics, or other techniques like bronchoscopy or navigation through several techniques are not accessible in all of the center, so we have certain limitation. And when the injury is deep or when it's close to the mediastin, it's the second transthoracic puncture. It is located behind the scapula and given the hard time to have access to it. Then diagnosis is even more difficult because we'll have to characterize the injury or the lesion as suspicious or not. And we'll have to consider some other factors like age, size, metabolic activity in the positron tomography, or the characteristic of calcification. We might define one or the other, or we'll do a follow-up. But this also fits into precision diagnosis to select our patients as they should, and we should not assume if there is high possibility of tumor. Sometimes we have to get into the lesion to do precise and early diagnosis. Many times patients, the ones I see, ask some other professionals, and they ask me when the other professionals do not offer exactly the same pathway to get to the right treatment. I think that's something we need to put into context in each scenario and in each patient. If a patient to do an echobronchoscopy needs to travel 400 kilometers to the health center and wait for many weeks or months to have it done because it's not accessible, there are surgeons in that hospital able to do a mediastinoscopy in a safe and efficient manner in a few days. Well, I think that it's more than justifiable. What I mean by this is that we need to do precision treatment and precision diagnosis, not in a systematic sequential way, not to do it all the same, but we need to select based on accessibility to testing. And this is very different based on the possibilities offered by different health systems. I know there are many countries in this call with different health structures, and I'm sure this reflection can be important for many. Here you have a picture of how to get to a same place through two different roadways and maybe at the same speed. But without any doubt, of all of the slides here, these are just screenshots of the clinical history of our Gallega community. When there is a diagnosis suspicion, and then they emit an alert to radiologists, we do TAC, bronchoscopy, PET. The most important one is the one at the bottom of the screen on the left, the multidisciplinary decision, where pneumologists and radiotherapists, oncologists, surgeons, radiologists, and pharmaceutics they help the decision making for diagnosis. And that's the part that shows and enrich the diagnosis to patient. If oncologists tell me, even if this patient has poor functionality and advanced epoch, take a good sample, because if he has any mutation, he will get benefit from it. Let's never give up, because we can get now to treatments that were unthinkable of in the past. And that just let me wrap up with this study, reflecting what I wanted to share in these few minutes. I was talking about how we need to. This study was published in Thorax in 2019. It's a clinical auditing done in England in 2015 with more than 33,000 patients, 129 different health centers. They evaluated many items and they created a score considering the ideal scenario to do therapeutical decisions and treatment offered to patients. They consider there should be one pneumologist, to have one pneumologist for every 200 cases, one radiologist with a third dedication, and medical oncologist with 1/3 dedication to lung cancer, radiotherapeutical specialist, clinical oncologist, and the presence of a nurse managing all of these diagnosis processes per every 80 new cases, and the creation of the diagnosis multidisciplinary committee, availability of PET in their own center and EBUS, and molecular techniques, and the stress test. Those are the ideal items combined that can make a good diagnosis. And based on this score, they will evaluate out of these, which ones of these have all of this. Not all of the health centers, like a rich country in England, have all of those quality items they consider when looking at the different possibilities in prognosis for patients. And this is a study of 2015. We were at the beginning of many molecular therapies, and probably it's been changed. In a clinical audit I conducted recently, 95% of the patients in Spain evaluated with advanced, they are presented to the multidisciplinary committees and they have molecular characterization techniques for them. In a multivariant study, they show that if you have a score going from 0 to 4, and they consider the reference value when starting treatment in an early case in less than 62 days, or the survival in the first year from diagnosis. If punctuation or scoring goes from 5 to 7, there is an increase of start of treatment by 14%, with curative attempt and survival above 1.1989. But when you are between 8 to 11, look, 49% of start of early treatment, 62% of curative treatment, and 2.30, meaning 2.30 times more probability of patient to survive. So let's include this precision diagnosis in the adequate techniques and through proper staging for the benefit of our patients. Now, let me conclude here, and some other topics open for debate. 4 conclusions. 1. Precision diagnosis is key to improve therapeutical approach of lung cancer and prognosis. The next speakers will speak at length. Point 2. This concept should include not only the type of tumor and molecular characterization, but also the correct staging and functional assessment To do so, it is necessary to have available professionals with experience and timely accessibility to instrumental techniques and new treatments. Multidisciplinary assessment in such a heterogeneous and complex disease is necessary. And now, I will be happy to take any questions. Thank you very much, Dr. Alberto Fernandez. Hearing your presentation has been very enriching. So let's not give up. Doesn't matter if the patient is senior citizen or in an older and more advanced stage than other techniques. That is essential because that is responding to what a patient would like and what their relatives would like to do as much as possible to try to save their life and try to give them quality of life. Everything you shared is very interesting. It's very important to have that expert committee, pathologists, radiologists, oncologists, and many others, as you said, who will give value to the diagnosis and to guide on how to do the precision diagnosis. Very important, everything you shared. We really thank you. Thank you very much for being awake at this time in Spain and sharing with us. Now, please let me go and check if we have any questions from the room. Just a second, please. Anyone who has a question, please try to raise your hand. Please, let's wait for a minute to see if there are any questions on the line. Just a second, please. So, think Maria o Mayra. Omaira says. Sorry, our line was breaking a lot, but we've heard this very important topic. I belong to the Patient Association of Chemotherapy. Many patients have lung cancer, and I was always I wanted to ask why there is so much incidence of lung cancer in non-smokers. Alberto says, I've been a pneumologist for 25 years and it was so weird to see lung cancer as second neoplastic. Thanks to the progress made and more survival in other lungs, we see lung cancer as the third neoplastics. In the past, there were only localized or vesical tumors that made the patient to get cured and then develop lung cancer. Now there are many cases. Many of the breast cancer patients have radiotherapy. We know that this is a kind of the consequences of those radiotherapies, of the ones that provide more radiation and damage structure, might be a predisposing factor in lung cancer. There's lots of progress, and sometimes there is an association related to biomarkers. Maybe oncologists later in the talk will give us more guidance on that. But one of the reasons might be patients that receive radiotherapy on breast cancer. They have as a predisposing factor like TBC, which is frequent in Latin America and Spain 2 decades ago. Those are predisposing risk factors for pulmonary injuries, like what we used to call scar cancer. Thank you very much, Omaira Gonzalez, joining from Panama. We are live in Facebook and all of the social network from ULACPUL. Any questions? We have 1 more minute. Any other questions? So, doctor will be happy to hear more from you at the closure. Now, Dr. Edgardo Santos, who is a medical oncologist of the Florida Precision Oncologist, specialist in thoracic oncology. He received the Spirit Award from the North American Society of Cancer and he chairs the committee of the Clinical Oncology North American Society, FLASCO. It's such an honor to have you here this afternoon, doctor. Be most welcome. Thank you very much for having me here, Carla. It's such a pleasure to be here with you. I'll share my presentation full screen. Just a second, please. Here we go. Let me know if you can see me all right. Yes, that's perfect. Well, thank you very much, Carla, for the invite. And thanks to all of the organizations related to lung cancer. I really like our patients to be organized. I've just heard Mrs. Omaira from Panama. I was born in Panama myself. And I did my internship in Panama and also my residency there. And at the end of the 90s, I came to retrain here in the US and do a research. And all of my research has been basically related to lung cancer. To respond to Mrs. Omaira, there's a lot related to the environment and exposure to radon. That's been considered one of the important factors in non-smokers developing lung cancer. Also, another type of toxic agents like hydrocarbons. It's not necessary for the patient to be a smoker. In those cases, chronic inflammation, and many times we have patients that have weakness, genetic weakness, and these patients develop for any reason mutations, somatic mutations, non-hereditary ones, most of the cases. And these mutations are the ones that we will see a screenshot of. We could have a 3-4 day talk on this and we will never forget. But as my colleague from Spain rightly said, this is a quite broad topic. Something we need to recognize is that lung cancer, the most important risk, you can develop lung cancer without having smoked. 25% of those patients, our current patients, didn't smoke. And why my colleague from Spain said it doesn't matter his age or her age, it doesn't matter their ethnicity, it doesn't matter if their gender. Every patient with lung cancer or with any other stage 4 cancer requires genomic profile, genomic study. And that's what we are pushing strongly in the US. And we are not doing so well, but little by little we are achieving this. But today we'll talk about lung cancer. So nowadays, you can see all of the 9 druggable pathways, the ones that we can attack through drugs. We have the GFR, ALK, ROS1, BRAF, RET, MET, anti-KRAS, and HER2. Now you get into Twitter, and each one of these mutations has their own patient group. We have the EGFR resistant, the ROS, and many others. And you'll see that each one of these mutations that we can discover through genetic studies, we can see the amount of drugs to offer patients. Many times they have achieved survival, or in other cases, they are in development to show that survival, but sometimes drugs show tremendous response and long duration of such response. These are the 9 druggable pathways for lung cancer. we have the expectation that the mutation of HER2 will have drugs approved by the FDA, and another one, NRG1. There are many others, SOF1, Zika5, HER3. Then there are many available for lung cancer. Now, to get to the analysis on finding those pathologies, there are different ways on how to do the testing. The immunohistochemical is the oldest one. It has preponderance in some types of cancer, like breast cancer, but PDL1, which is a protein expressed, offers a better target for inhibitor checkpoints, which is a way to activate the immune system, and it has become very important. They started to appear in 2014, 2015, and approved by the FDA and the European Union and Asia. So, immunohistochemical is important and not expensive. Next one is the FISH. This is most important when we have arrangement in chromosomes, rearrangement, and for copy numbers of certain genetic alterations. Then PSR, as you know, it's been used for long, and that's one of the ways to confirm diagnosis of HIV through polymerase chain reaction. The problem with this is that it's very specific and it requires different probes to analyze each one of the genetic alterations, and we need to know what we're looking for. So that is good for rearrangement, for copy number, and also for variants when there are point mutation or indel that are part of the exon. And the newest technology, which is next generation sequencing, with a tiny bit of tumor or with a blood sample, we can analyze thousands of genes. And nowadays, here in the US, we consider that's the gold standard. And in the case of lung, that's the goal of cancer in thoracic oncology here at the US. So, next generation sequencing could be done and there are many genes, and through those genes, we can see the analysis of nucleic acid and ribonucleic acid. We are not only talking about NGS, DNA, RNA. Now, next generation sequencing allows us to evaluate substitution of base pair. For example, KRAS, which is a variant of a nucleotide. We also have deletions and insertions in GFR for the injuries of exon 19 or an insertion in exon 20. Number of copies, we can see the copy number of HER2 and the latest one, which is the translocation on chromosome rearrangement taking place on the chromosome or with another chromosome, and we have a great variety like ROS1, ALK, NTRK, and many others. It is super important to conduct RNA analysis in there. If you are going to study tissue, the tumor molecular profile, every time I offer a lecture, I recommend using a platform that has next generation sequencing of DNA and RNA. DNA will let us study the exon, the complete sequence of the exon. RNA will allow us to study all of the transcription and protein analysis. With that, we'll have a complete analysis of what is happening in the cancer, not only lung cancer, but in any cancer where we are exposed to molecular analysis of this type. This is just an example to show why the transcriptome is important. In this study of Dr. Berayer, all of the patients were lung cancer patients. 2,232 were analyzed with DNA, and they were, or 232 out of those 2,522, those patients didn't have any driver mutation, allowing the evolution of cancer, meaning those 232 patients, there was no driver mutation. So these patients were analyzed with a RNA, and 15% of them were found to have an oncogenic driver that was not detected in the DNA. Those 33 out of those 36 had alterations for which we had drugs. So that's the importance of not only studying the exon, but also the transcriptome of cancer. And when we put all of the technology available, there we have the DNA sequencing, the RNA sequencing, immunohistochemical. There are 15 biomarkers that are done with immunohistochemistry, and also fragment analysis and pyrosequencing that will be important to discover some other alterations in genes that are more difficult to find through the other ones. One pathway is very common for pyrosequencing, and fragment sequencing is important. Fragment analysis is also important when there is a discrepancy on how to study microsatellite stability. There are many ways to analyze that. There is a discrepancy, so we do a fragment analysis to confirm which of these is specific of this tumor. As you can see in these squares, there are all of the drugs that can be provided if we find the alteration, the molecular alteration, or the proteinic alteration using all this type of analysis, but in only one way. You can do all of this in just one go. So next generation sequencing, the clinical utility is basically finding a specific mutation. There are some of them that will let us find certain targets, what we call agnostic biomarker. It will also let us analyze patients. Once the patient starts making progress, we take another biopsy, tissue or liquid, to see what's the resistant mechanism, and in that way we can apply drugs that can fight that resistance. It also let us find new targets, and also analyzing tumor at a deeper level. It will also let us enroll patients in clinical trials. At the end, that's what you know as precision medicine, individualized medicine, or customized medicine. To do so is why we do molecular studies. We have worked many years and many decades after we got to recognize of the small cell cancer, and the small cell cancer was split into squamous cancer, adenocarcinoma cancer, large cell cancer. That was the histological part, but that was not enough. Now we have to go deeper, and my colleague from Spain was totally right. Very soon, and it's already included in the guidelines in the US, we are recommending genetic analysis for squamous cancer patients. And this is the molecular pathology. With the progress of immunotherapy, we can get biomarkers like DL1 and the mutational load that we can only analyze at this point in time through next generation sequencing. We analyze thousands of genes to know if the patient's tumor has much variability, mutation variability, that makes it more feasible for the immune system to recognize all of those mutations as proteins, none of the system, and lymph cells attack. We see how we went from the traditional view to the present view. This is molecular medicine. Now, let's talk about liquid biopsy. This is very important because of many reasons. First place, it's easy. Taking this blood sample doesn't take a minute, and it's non-invasive. And apart from that, the time it takes for getting the result is super impressive. It's super fast. Let's look at this study located in a New England Journal of Medicine. This is a kidney cancer. Dr. Gerlinger and his colleagues had 9 biopsies, and they found different mutation in each one of those regions. Only 34% of the mutations were present in all 9 biopsies. So you can see this heterogeneity taking place when you're doing tissue biopsy, because it depends on what is specifically on that needle. But we cannot do many passes in a tumor that can lead to complications. But that gives you an idea that a mutation that could be addressed can go unnoticed. Now, over here, this compares tissue of next generation sequencing versus plasma. In 165 cases of paired samples from 5 major centers in the US. Let's look at sensitivity of cell-free DNA. It's 85% for blood and 80% for tissue. Specificity is very similar. And accuracy and the precision accuracy of both, even in blood or tissue, is also similar. Over here you'll see that in blood, when they compared this particular test, at that time it only had 54 genes. Now it has 73. When it was compared with a whole exome sequencing, we see that the specificity was 99.9%. And there was only one case, one false positive, that was sent to be checked in Stanford University. It was wrong. It was correct in the biopsy, in the liquid biopsy. How does it work? Well, basically, liquid biopsy depends on the tissue sending tumoral cells to the blood. That tumoral cell will die on the blood, and there will be circulating DNA. And that's this liquid biopsy in this case. In the Gardel 360 captures this ctDNA and analyzes this in a genetic sequence, providing results of what is happening in the patient's system. It is important for lung cancer to not miss any of these pathways to provide targeted therapies. There you can see all of the pathways we currently have approved, not only in the US but in many other countries. It is very sad when we look at this statistic. Less than 50% of patients with documented EGFR or alterations were treated with tyrosine kinase inhibitors. That is depressing. That shouldn't happen. A patient with EGFR and ALK mutation should start to be treated with these agents, oral agents. It is not systemic, it's not IV. Why? Because that was not only above chemotherapy, but it was superior to chemotherapy and superior to immunotherapy. Going back to tissues, it is a long process, has many limitations. We only have what the pulmonologist got to retrieve through the directed needle in the CAT scan. We can only work with the samples obtained. So I asked my colleagues, the radiologist, large biopsies, one for histopathology and what is left for genetic, and only exclusively for genetic, for us to understand what is happening with the patient. Why? If there is a small tissue, For do the histopathological, if he is not careful, he can damage the tissue and making large series of immunohistochemical. The idea is to get the diagnosis and to have remaining tissue for molecular analysis. If not, we've done nothing at all. This is to let you know that when we treat patients with targeted therapies, the response ranges between 50 to 83% in targeted therapy. If we treat that patient with immunotherapy because the doctor was too busy, look at the response rate. Poor response. I have patients with EFGR sensitive and PD-L1 of 90 to 100%. I tell them, I'm sorry, we have to wait. We We cannot rush because there is high PDL. If that patient has a driver mutation, immunotherapy will not help. The first line of therapy is targeted therapy. Let me share one patient case, clinical story, 44-year-old female, presented persistent cough and weight loss, diagnosed with a stage 4 lung adenocarcinoma, also brain lesion. Oncologist ordered tissue sample and liquid sample, with the difference that liquid came back in 7 days with red fusion. This patient was initiated with selpercatinib and that provided good brain response. So those patients that have brain injuries asymptomatic, not necessarily we need to rush and give them radiation because now there are plenty of drugs that can cross the encephalic barrier and in many cases get to a complete remission or disappear those brain lesions, and that they have to be treated with one of these drugs. Another case, 64-year-old female patient, light smoking history, admitted to hospital with massive stroke. In hospital, they found she had a lung mass with bone metastasis. They did GBUS and they showed lung adenocarcinoma. Pathology showed she had PD-L1, showed 16% expression, and guideline recommended liquid biopsy and 7 days response. And she got EGFR exon 19, that was one of the most sensitive to therapy. She has 7 lines of therapy possible. She was put into EGFR and she went into total remission. This is important, what I was discussing about liquid biopsy, precision and how fast it happens. This is important because in lung cancer, we have to be very careful. If a patient doesn't have molecular studies done and they are treated with immuno and chemo, if he has a mutation we don't know, he won't get good response. If molecular studies are done, PD-1 comes in 2 days. Most hospitals can get it in 2 days. You'll get results in 2 days. It's too high? Please do not start immunotherapy until you get a complete molecular picture. Because if he has EFR and it's not properly treated and it starts with immunotherapy when he wants to change to adequate therapy, that patient might have adverse reaction, even fatal immune adverse reaction. So advise, wait for the whole molecular picture. This is a prospective study of Dr. Natasha Lay of 282 patients with tissue test. There are many platforms here in the US. All of them went to liquid biopsy with this Guardian 360 study. The objective was to compare biomarkers recommended by guidelines and the time it took. Liquid biopsy was superior than tissue. 98% concordance for the 4 biomarkers that existed in 2018. 3 years have passed by and we have nine biomarkers. Look at the great progress made in lung cancer for therapy. 27% more patients with biomarkers detected when using liquid biopsies over tissue. Both have next-generation sequencing, to give you an idea. And the time where it was published was 15 days for tissue, 9 days for liquid biopsy. At the end of the study, the median turnaround time to receive result was 9 or even down to 5 days to receive the results of liquid biopsy. Therefore, one of the issues is to do tumor in next generation sequence DNA plus minus RNA should be both, as I said. Many of my colleagues versus plasma DNA. Plasma was left behind. As I said, very soon there will be this platform showing liquid biopsy studies of blood. They will have both DNA and RNA. This is the study of Dr. Agarwal of Pennsylvania University. Look at the importance of liquid biopsy here. In this inclusion here, in this institution, one of the best ones in Philadelphia, 44% of the patients that had tissue biopsy were unable to get tissue results because of tissue insufficiency. But if you send them both at the same time, if 3 weeks after the tissue comes with nothing, you'll probably be able to get something from the liquid biopsy. If the patient has a real stage 4, what do I mean? Lung cancer with different injuries, bone or lesions in bone, and some others. There are some patients that come in stage 4 because of both lung diseases, but he doesn't send tumoral cells to the bloodstream. So the possibility of finding circulating DNA is minimum. Because of these studies, especially of the one Dr. Lay that said more than 20% of the patients with biomarkers nowadays in our thoracic society, they are proposing, they are suggesting to do first blood and second tissues. Here in the US, this is the one that they use the most. If in an order you order 2, first goes blood. If nothing is found, when you order the blood, you are also asking for tissue. If in day 7 there is no blood results, the company will have the tissue in their lab and it will take 7 or 8 more days to obtain results, tissue results, making a total of 2 weeks. And this is my conclusion. There are many drivers and mutation drivers we need to identify. We cannot have lung cancer patients stage 4 without molecular studies. There is no excuse now of not having enough tissue because there's liquid biopsy. We must do better. Even in the US, in a study presented in recent Congress, in the ASCO this year, Dr. Di Bono from Boston showed concerning numbers. 55% of patients had molecular studies done in the first line. Stage 4, 100% stage 4 patients should have molecular studies. Else we will not be able to improve the survival rate of our patients. Here you have my contact information, my Twitter. Feel free to write to me. And there you have my 2 emails, and you can also find me in LinkedIn. So here's my information. If you need anything from me, please contact Carla. And finally, let me invite you to all LATAM for the schools of thoracic oncology supported by the ASSC, International Association for Lung Cancer Studies. I am co-chair of this and also co-chair of this Congress that was going to take place in Uruguay. From our friends in Uruguay, it was going to be in Uruguay last year, but because of COVID, it didn't take place. Now it will be a virtual Congress. But next year, hopefully, we might visit Uruguay for the LAICA, Latin America Lung Cancer Congress. So there you have, there will be, I don't know how to say it, patient advocacy groups. There will be a forum for patients there. There will be radiation oncologists, pulmonologists, surgery schools, pathologists, and nursery. So please join us on December 3rd and 4th. You're kindly invited for complimentary registration. Thank you very much. Thanks to you, Dr. Edgardo Santos. This conference will contribute a lot of knowledge, and civil society is also there invited to this Patients Association, so it's important to attend. Dr. Santos, thank you very much for all the good practices shared in the US and the devolution on a precise way to patients. That definitely is the future. If we properly diagnose, we will know what to give to each patient on this patient, on this therapies. I would like to give it a go to Briseida Castillo from Costa Rica. She had a previous question. Thank you very much. Let me congratulate Doctor. It was an excellent presentation, and I'm very happy to see the different alternatives of new drugs with more and better options for patients. Like in everything, the urgent thing here is the diagnosis, early diagnosis for higher survival. Question that is not clear to me is the pleural is typical of patients, derrame pleural. It's typical for breast cancer patients causing metastasis in the lung. Pleural effusion or pleural spilling could be caused by any metastatic lesion in the pleura. There could be patients that are diagnosed through the pleural spilling if it's malignant, and it could come from the lung or the breast or ovarian. It could be many cases. It could be many types of cancer leading to malignant pleural spilling. Thank you very much, doctor. Thank you very much, Dr. Santos. Let me please confirm if we have Dr. Mota here with us. Yes, here I am. Good afternoon. Thank you very much, Dr. Santos. Now let's welcome Dr. Rodrigo Mota Guerrero, oncologist doctor, graduate from Cayetano Heredia, member of ASCO, ESMO, and ISCL, oncologist doctor and researcher of thoracic neoplastics of Aliada Peru Clinical Center. Be most welcome, doctor. It is an honor to be here with all of you today, talking about our experience. Before, let me know, please, if you can hear me all right, if you can look at my screen. Yes, doctor, everything all right. Good afternoon. I would like to start by thanking for having me here and to meet you all and to talk a bit about our problems. And I hope this could be understandable in the way I want to explain. First of all, as we all know and has been presented in the previous talks, lung cancer is a world problem, and as we see, the report from last year, lung cancer keeps being one of the most frequent neoplastics. having one of the highest incidences reported. And as we can see in blue, the new diagnosis made a year, and in red, the mortality of patients. If we could compare this with other neoplastics that are maybe more frequent, like breast cancer, we see breast cancer in blue shows new diagnosis, and we see how much bigger it is than the red one representing mortality. But look at this. It is not the same when lung cancer. With lung cancer, red represents mortality, and you can see it's way closer to the number of diagnoses conducted. That's one of the problems. If there's lots of drugs that have been moving in the first, second line of therapy of advanced lung cancer patients, mortality is still high, and we expect this to change as time goes by. As Dr. Santos properly presented, there is now lots of biomarkers, and there are many targeted therapies that will target every molecular alteration in advanced cancer patients. That's the first thing we need to emphasize. We are no longer talking about advanced lung cancer as a disease per se. We talk about molecular type in lung cancer. We talk about the type of mutation that, as the doctor said, there could be some driver mutations. There's much to know about lung cancer, mutagenic diseases with high expressions of TMB and antigens. And this is associated to a good response to immunotherapy. We also know about the presence of activated cells, and all of this is associated to a microtumoral environment that can express high response to immunotherapy treatment. That's precisely what I would like to highlight in this talk. We've heard one of the treatments that we heard more about the last decade is the tyrosine kinase treatment. We know that FVR has a component or structure, transcell structure, intra and extra, and as we know, the tyrosine kinase domains are associated to the development and activation of a whole molecular cascade that will end up in the MT that will lead to cell proliferation, metastasis, and the development of a tumoral environment. Tyrosine kinase inhibitors have the work of blocking this pathway, and by doing so, they have a positive impact on the life of patients. However, we need to take into account something. Tyrosine kinase inhibitors are in the guidelines and have been there for many years, since the first inhibitors of first generation, from ositinib, and third generation, like these ones here that came with this study. Flaura was a phase 3 study that positioned tyrosine kinase third generation as the preferred ones, first line for advanced lung cancer that have a sensitizing mutation. This study compared TKI third generation versus ERLO or EFI, which are the treatment of TKIs of first generation. And as we all know, if a clear benefit could not be established with this versus the first generation, couldn't be established through a methodological design. Remember the crossover that was permitted in these patients that were progressing in first line? with Evelyn on ERLO, if they had a mutation. This could affect the study, and somehow it could prevent expressing a statistically significant benefit in the survival. However, the endpoint of the study with PFS median there shows a clear benefit of, there is a background noise. The ones that received TKI of third line had a benefit of 8.7 months extra in favor of the ones that received only the TKR of first line ERLO. This difference had significant relevance, statistical relevance. That was a very significant finding with osimertinib. As you know, it plays a role and a benefit at the level of the central nervous system that is not achieved by the TKI of first generation. That's why we prefer to use this one. If you look at the current pathways, whether they are SCCM, TKI of third generation, have the same category 1 as SCCM as the ones of first generation, but the ones of third generation, like osimertinib, are the ones preferred. My point is, this made osimertinib to be moved to first line treatment, and as I said, it's the preferred first line treatment. Even though we can say erlotinib could be used in first line, and patients making progress are done, or they do the molecular study and they can benefit of the osimertinib of second line. Doing this sequencing in theory gives a benefit on PFS of 20 months. This is something very similar of me giving alternative NIF in first line to patients that have a mutation. Now, we need to take into account that if I prefer to give osimertinib in first line, is because patients that have progression in erlotinib and couldn't receive this other one, the ones that have the mutation of T790M is not the total of the patients, even though it's one of the most frequent mutations. Around 60% on average of these patients will have this mutation. And we need to take into account that not all the patients, when they move to first line, will find optimum conditions of receiving the second one. Let's remember that many of these go to the nervous central system and they're in a clinical stage that will not get benefit even if they get treatment. That means that patients that get to osimertinib second line is lower number, relatively lower number. We're talking about 40-45% as we see in our day-to-day practice. That's why osimertinib gets in first line. And even though we might say that we have got to this preference point, we regrettably find a reality in our reality that osimertinib is a drug which is very expensive. It's not my intention to talk about prices, but I need to mention, and my intention is to talk the real day-to-day practice in our reality. And truth is, osimertinib is very expensive for most of the health systems. There are two types of health systems in my country, and regrettably, none of them can cover treatment with osimertinib. And if we use osimertinib, it's only in private practice. Let's talk about ALK arrangement. I'm not going to go deep into this. It's been properly explained in previous talks, I would like to emphasize the importance of determining the molecular status in each patient. And that's something that we do in each center, in each hospital and health system. ALK mutation is it's not frequent. We have very low mutation, below 5%. I forgot to mention about the CFR. If you look at world data, around 12%, 15%. But in Latin America, the rate is way higher. In my country, in Peru, there are reports saying that our rate of SVR mutation rate is 30-40%, so high. We have alterations, particular alterations, and they put us as a particular population, and it offers responses to different treatment, and that's a reality in each place. That's something that needs to be seen, because it is very different to see the mutational profile from Hispanic and non-Hispanic patients. And mutation of a lung cancer, advanced lung cancer patient coming from Latin America or coming from Central America or the US or the one coming from Europe or Asia. So about ALK, there was benefit found when treating this driver. We know the profile determined that the application or use of this versus chemotherapy gave patients a higher benefit. As you can see, more than double, achieving statistical significance. 4 years have passed by from the ALEX studies comparing alectinib with crizotinib. Alectinib had more effect on the central nervous system, and this is a drug that needs to work in advanced lung. And advanced lung should have good efficiency, anti-tumoral efficiency at the level of the central nervous system, and it is well known the facility with which lung cancer can get to this level and have recidivism operated, or patients that have advanced stage disease can get these cases get into the nervous central system, and the ALEX study found benefit on patients receiving alectinib that had higher effect at the central system, and they have over survival, 15 months of advantage, reaching significant relevance, as I mentioned. My intent here is not to go deeper into this type of treatment because it is well known, but simply this slide is to remind you that the profile studies put crizotinib as the agent to be treated in lung cancer, advanced lung non-small cell cancer. Next year, we had studies 2 and 3 putting serotinib as one of the options, and creatinib, brigatinib, and alectinib. And finally, lorlatinib, which is also an anti-ALK TKI that offers good results in the survival. And now the objective is to determine which is the sequencing, the optimum sequencing for the use of anti-ALK treatment in those patients that have ALK rearrangement. My objective is not to go deep into these topics. My objective is to explain that, unfortunately, this type of medication is only provided for treatment through private insurance. Patients that have public health insurance they do not have access to crizotinib, and not even the least to the other new drugs that like lorlatinib. that are providing most benefit in cancer cases. As mentioned, not giving anti-ALK treatment for patients with rearrangement of this mutation is regrettable, is unfortunate, but it's something that we see in the day-to-day here. This is just to remind immunotherapy. Immunotherapy has changed the life of patients in general, the ones with different types of cancer. And we can see immunotherapy in neoplastics, in different scenarios, in different treatment lines. We see how this knowledge, the most profound knowledge from the molecular point of view, on the expression of PDL, PDL1, CV28, allow us to have enough knowledge to try to know that the blockage of one of these can bring benefit in patients. And this is something that was determined. Patients that have high expression of PL1, like we saw in Keynote, Empower, and 131, those that received Immuno had more benefit in global survival, getting differences of 10 months, 9.5 months in the studies where immunotherapy was added to chemo as first line, and it was compared to the treatment with chemotherapy. All of these changes were significant, and they were revolutionary somehow, and they changed the face of changed the situation of patients with lung cancer. And some others, they are very tolerable and have manageable toxicity in most of the patients. And the ones with PDL1 high expression were also benefited from offering this treatment with immunotherapy alone without adding chemotherapy. And this was shown in the Empower and 1010 Keynote 42. And little by little, we see more and more updates of all of these studies, like the one of 189 last year, the one coming from Empower 150. And we notice that the expression of PL1 high, more than 50%, lets us offer immunotherapy to patients. It is highly manageable. It allows patients to have good life quality and continue with their day-to-day activity. And this is the objective we look for in these types of scenarios, to increase life as much as possible and to increase that, giving the patients a life that he'll enjoy and he can continue with. And we can see the benefit of obtained is 7 months, 8 months compared to immunotherapy. These are interesting results. As Dr. Santos also said, we need to take into account that TMB has been studied in this field in advanced lung cancer, and they are studied with immunotherapy, in this case, PLB with high TMB, and also the Checkmate 568 in lung cancer, advanced lung cancer, with TMB, high TMB. And as you know, the results were very interesting. Results allowed to see that patients that had high PMB and that received blockade had higher benefit in their survival over to those ones that received only immunotherapy. Duration of response was positive in favor of those that received double blockade with immunotherapy. Look at how these two curves split. how many studies we know that offer this type of curves at this level of separation and these opportunities. So, same way, here it is found that there is benefit in the patients with high TMB. All of the ones that have PL1 high, PL1 higher over 50%, or those that want high TMB, based on the CheckMate 168 with a TMB equals or higher than 10, had higher benefit with immunotherapy. My point with TMB was also evaluated in other studies like these ones on the screen. Keynote 10 and 42, determining that patients that had high TMB were associated to the application of immunotherapy. Detail here is that immunotherapy is one of the most expensive treatments. This is one of the treatments that generally is used. It has more limitations in clinical practice. This toxic, it's not tolerable by all patients. So there are other treatments most widely used on the day-to-day. But as we know, the use of this type of drugs considered high cost. High cost is not completely well defined. But those drugs are not affordable by everyone. And they are only seen in first-line therapy for patients that have private insurance. Same thing for MSI high. Patients with deficiency in the repair system of DNA tend to have higher mutation rate, and this is expressed and associated to better response to immunotherapy. This is what I mentioned. Patients that have high expression, high micro... Sorry, line is breaking a bit. This is a point that could also be used as a biomarker in advanced lung cancer with serious mutation. This has limitations, obviously, and this is one of the limitations that we need to take into account in health systems, because if you can mention that you could use caries and accumulation mantis, and you could also use different NGS studies, not all of the tests. Not all of the tests are accessible in every country. Health systems have no accessibility of these tests. In the private, you don't have access to all of the tests in private practice either. So definitely, you have to look at each patient, look at the characteristics of the patients, and see what's the best option that you can give, taking into account the different characteristics of the patient and the different weapons you have to offer them to patients. As Dr. Santos said, there are mutations like HER2, ROS1, TRK in advanced lung cancer. They don't only evaluate LK or L1. They are looking for series of drivers, and if you evaluate the latest update of the NC, there is treatment in first line for each one of these mutations. In advanced lung cancer in the near future, seems to be very good, because patients that used to have these mutations in the past and because they didn't have evidence of any drug or targeted drug for this type of mutation, now there is one, and there is more tests and more studies, AC3, and we expect them to keep having a positive impact on the survival of patients. And what's the evidence we can get of those studies that we are doing nowadays? Real quick, about what we are doing in our country, we're emphasizing association with biomarkers, inflammatory markers, and associated to a good response in patients with lung cancer that have sensitivity. This is one of the studies that we published in the oncological journal. Our oncological journal is one of the private centers. We have 50 patients that have received the first line with AKIs. Only 12 received third generation first line. And we expect this figure will get into the public health systems. Hispanic people had a different mutational profile. This publication is 4 years old, and it showed how we had a different mutational profile from different ethnicities. We have higher rate of CTKA are different. All of those rates are different, and they are associated to the lack of response of some agents in immunotherapy. And just to wrap it up, the mutational study of the molecular status of advanced lung cancer allows you to choose the therapy that will benefit each patient even the most. Accessibility to medicine or drugs in public health center is a constraint for the best treatment for our patients. There are more and more drugs discovered, and they are adding more treatment to the first line, second line of lung cancer. And in private insurance, it is becoming unsustainable for them to cover all of the treatments for our patients. So we need to evaluate well the best medications that bring the most benefit in methodological real benefit, well noted in each clinical trial. Let's also remember that the best treatment is prevention. Some days ago, we had the International Day to fight lung cancer, and the best weapon we have is prevention. That is my closing remark. Here you have my email. If you're interested in research and sharing data and sharing evidence, in our oncological center, we are open to that. Thank you very much for this opportunity. I'm sorry I spoke at length about this, but this is a very important topic. Thank you very much. Thank you very much, Dr. Mota, the passion that you transmit your knowledge with. We are highly satisfied with everything you've shared, Dr. Mota. We loved to hear that prevention is the best weapon to fight cancer and lung cancer, of course. And now, let me thank you for your presentation, and over to Mercedes, who is raising her hand to ask a question or a comment. Over to Mercedes, please. Over to you. Mercedes says, Thank you very much. Yes, one comment about the precision in diagnosis and how important it is to do it for patients with lung cancer. And I would like to talk about my mom's case. She's a patient that in 2012 was detected with lung cancer. She never had symptoms. They did the X-ray to her and they noticed a spot. However, radiologists didn't even observe that as a material observation. Pneumologists did, but she asked for a CT and there was a black spot. In 2012, she was operated. She had lung cancer stage 1. She had a surgery, and then there were many tests to see if everything was all right. During 3 years, she was clean. In 2015, it came back. At that moment in time, there were 2 spots, and they did a physical biopsy on what they had previously rescinded in the taken in the first surgery, and they did a liquid biopsy. They determined they had GFR mutation, and they gave her as treatment erlotinib. Since 2015, she was in constant checkup, taking these drugs, and her survival was 5 years. She died in 2020 because of a complication with the cancer. But I'm sharing my experience for us to look at the importance and precision in diagnosis, survival, and the quality of life given to patients, and how important this is for this to be applied in our country. She had particularly private insurance, and we were able to cover treatment with that. Nowadays, that for every Peruvian, that's not affordable. And I think we should have more initiatives to support this. That's what I wanted to share, Carla, with my mom's experience. Thank you very much, Mercedes, to share your experience. Such a significant Mrs. Elena Lostanao was able to share this fight from her position as patient that had access to precise diagnosis and treatment, precise treatment. She had a great quality of life and a higher survival than usual. And she preached and promoted for Peru and Latam all of the patients to have this access. It is necessary for us as patients associations doing advocacy in our countries to ask for this improvement in health system. Dr. Mota said, all of the health systems have access. There's major progress in research. There are great possibilities for patients with lung cancer. As Dr. Santos, with 9 genetic mutations, there are many possibilities, but we're not getting access to those. So I think that's the essence of the issue. We need to put this in the agenda in all of our countries and be able to dialogue and verify what we really need to have, at least in our countries, for lung cancer, and move as a bloc in Latin America. Now, please, I would like some 2-minute closing remarks to the doctors here with us. Dr. Alberto Fernandez, over to you, please, if we could have your opinion. Yes, I totally agree. I thank the speakers, the oncologists, for their excellent review and work, and I think the patient with her testimony has said something that will change totally. Even in local stages, treatment should be maintenance treatment if there are specific mutations. And there are promising results there. We should not forget, even in stage 1 or 2, patients that had curative surgery had a recidivism index and mortality here of 5 years. The situation shared, maybe in the near future, shouldn't happen, because we'll have to do analysis of those mutations even in surgical removed. I wanted to mention 2 aspects: multidisciplinarity and accessibility. Lung cancer has a priority in all of the countries because this is a pandemic. a pandemic so important that will persist for longer than the one we are having with COVID. Data, there's high mortality rates, and even though the future looks promising, we're always late. Thank you very much. We hope this changes in coming years, and thank you very much for having me. Thanks to you, Dr. Alberto. Dr. Edgardo Santos, please, over to you. Doctor, sorry, I think you're mute. You're mute. All right, I agree. I totally agree with my colleagues. Thank you very much, Dr. Fernandez. Dr. Mota in Peru. Dr. Mota said something at the end. That's something that we always fight and keep fighting with, is other organizations on how to get access to these drugs, because this is a global problem. As Dr. Mota said, I know these problems exist in our countries. In my own country, in Panama, it is difficult to get this molecular analysis, even in private and at institutional level. In the part of public health, it is very difficult. And yes, they are the cost and all the rest. With this company, Garden Health, I had the opportunity of helping patients there in Latin America. I think they have offices in Colombia, and from there, colleagues can send tissues or samples to lab in Colombia. Then we have to consider cost. Like the patient treated with erlotinib, I think she mentioned 5 years ago, when there are some drugs that are more powerful than erlotinib, like the third generation. Those are the things that in the ILC we want to be removing little by little, how to try to help other countries to have access to the best possible drugs. Not that one that is the effective, but the best one, because everyone deserves to be treated with adequate therapy. Thank you very much, Dr. Edgardo, and thank you very much, Dr. Alberto, and thank you very much, Dr. Mota. I would like to greet Mrs. Mayra Galindo joining from Mexico, Briseida from Costa Rica, Nancy from Chile, Alejandra Córdoba from Colombia, Mayra González from Panama, Mercedes Onofre from Peru, and Entorno Vital from Colombia, Sandra Francisco from Chile, Deyanira Hernandez from Costa Rica, Elena Esteves from Brazil, Sandra from Uruguay and Mexico, and all you who joined from different places. Thank you very much, and we respect you. I'm sorry we took a bit longer, but it's been very good to be here with you. Thank you very much. Thank you so much to all. Thank you very much. Have a very good afternoon.
Muchas gracias por esta invitación.
Gracias.
Maravilloso.
Un gusto compartir. Hasta luego. Abrazos.
Maravilloso.
Abrazos para